Would like to discuss in some detail two basic questions of volar plate application. One involves the idea of the adequate length of the distal screws that's required to provide stability, and secondly, whether or not there's any advantage to trying to deliver the screw into a dorsal displaced fracture fragment. The second part is the ideal plate length and position. Whether or not the important position to place the screws with the plate on the volar surface jeopardizes the possibility of later tendon rupture. We'd like to suggest that the placement of the plate may influence subsequent tendon problems, and it's important to consider in the surgical technique. Based upon biomechanics studies and clinical issues, we found that these being functionally shaped like screws, but actually functioning like a blade plate or a locked plate screw construct. That is, they're not really functioning as a screw had functioned in the past when it was not locked into the implant. The way a screw would normally function is to capture the opposite cortex, and by tightening it, it's bringing the implant into the near cortex, providing stability and compression. Because the difficulty sometimes of understanding where the tip of the screw is related to the dorsal cortex, there have been very clear incidents of tendon ruptures on the dorsal side due to protuberance of the screws. Therefore, by virtue of the understanding that enough stability can be provided without having screws go into the opposite cortex and the risk of future tendon problems, most have suggested shortening the screw length to 2 to 4 millimeters below the cortex. The other situation is whether or not we have dorsally displaced fragments that may be better attempted to capture those fragments with the screws. So we're going to look at a few images to promote discussion on this subject. In the first place, which is the ideal plate position? We've learned from several studies that if the implant extends distal to what might be considered a safe zone, its prominence can be a risk for tendon rupture. This position has been documented in several studies in North America, and more recently, a study by FUFA in Hospital for Special Surgery using ultrasound has demonstrated early tendon irritation way before clinical presentation in the situation of implants in a strategically risky position. Second, as I mentioned, is what's the ideal screw length and what's the position of the screws related to the position of the plate. So there have been several studies that have suggested that in simulated osteoporotic fractures with a volar plate, that 3/4 of the length from the volar to dorsal surface of the screws would be sufficient to provide satisfactory stability. Our cartoons or schematics throughout this presentation will show this difference. It will show screw position and length as well as plate position and length, and look at how both may influence stability. In this extra-articular fracture, we see the plate position to be satisfactory in the sense of the prior studies that it is close to the surface of the volar cortex. And in the volar illustrations, we see the similar position of the plate, but with different screw lengths, one being the ability to capture this fragment. In this case, with a dorsal ulnar corner fragment, the question is, can we or should we place our screws more into the dorsal fragment, trying to capture it, recognizing that it's not truly a function, recognizing that it might extend through the cortex. And here's an X-ray showing this. We're also seeing on this cross-sectional CT scan that we have a screw coming from an implant that's in an incorrect position in the sense of being too distal and being within the unsafe zone described by previous investigators. Whereas in this situation, the screw attempting to capture or be placed under the subchondral bone of the plate in a good position. How do we define the position? Well, described by Soon is if you drop a line from the tip of the volar cortex, If the plate sits closer to the volar cortex, it's considered to be a safe zone. If we look at this, then we realize if we drop this line, the tip of this plate is sitting anterior to it and representing a risk factor. But we can look at a few images to promote discussion on this. These images come from the ICUC database that has data of the images, the care, and the outcome from start to finish. We've illustrated to help understand this by schematic and coloring in the fragments. But here's a case where the screw has captured into a large dorsal fragment. Certainly this would seem very appropriate given the dimension of this dorsal fragment. However, looking at it from the volar tip here, we're realizing that this is an unsafe position. Rather, if we look at this situation, we have the screw from a less amount of a screw into the bony fragment, but in a safer position. Is this screw capture as stable as the first one? We don't know, but many would believe it is. And if you look at this schematic here, here's a protruding plate with 100%, meaning the length of the screw going all the way through the dorsal fracture fragment, versus a protruding plate with less option in capturing this. Certainly one would feel much more comfortable with this, yet the risk of the plate causing tendon irritation is substantially greater than this. And we believe that the capture can be done equally as well with the plate in a safe position. With the ICUC experience, we're able to follow patients long term and have come to realize that rupture of these flexor tendons can occur almost at any time unpredictably after volar plating. Enough so to begin to think that perhaps, especially in patients under the age of 45, all plates should be removed. And here, strength of the ICUC database is a long-term follow-up with both functional, patient-rated, and radiographic evaluation. Let's look at this patient. Here has a very displaced multi-articular fracture, as you see illustrated in these fracture fragments in color. An unacceptable position, we would say, from the plate with the screw capturing this fragment very well. And in these schematics, with the plate changed in the overlay, perhaps you can do the same with a more appropriate position of the plate. And here in the real life CT, we see that plate screws are capturing that fragment effectively. But once again, in this illustration, with a plate in a dangerous position, we see the screw into the dorsal fragment, but we can do the same with a plate screw construct in the volar side in a more appropriate position, recognizing that many implants provide the ability of variable angle placement. And so even from this position, using a variable angle, we can get this in a better position. And here's a follow-up. Once again, we'll illustrate this in a 4-part articular fracture. And this is the illustration we see here from the plate in a risky position, just extending beyond the safe line, capturing it the same way with the plate in a safer position, angling the screws more distally. Does this screw provide stability of the fragment? In a fragment this size, it certainly does, and therefore is strategically relevant to do that. Another case, these are all very complex cases with very displaced dorsal lunate facet components. Plate strategically is in an adequate position and good function. Plate was removed electively. See a maintenance of a nice position and a nice result. So we wonder about both plate position and screw length, and whether or not one is important enough to warrant, that is capturing the dorsal lunate facet, important enough to place the plate in a less optimal position. One more case we'll illustrate, and this is a clear dorsally displaced fracture with a major component of a lunate facet. We see the plate placed here and the screw capturing it going just through the dorsal cortex in the post-op CT scan. The functional outcome is illustrated. We would agree that striving to put the plate in a better position, using the screws to grab the large facet, but perhaps using angular stable fixation, would be preferential to having the plate more distally and having a more vertical placed screws, which may support the subchondral bone a little bit more appropriate theoretically. The message here are twofold. One is we've identified the fact that the placement of the plate on the volar cortex is very important. As people's experience extends longer and longer, we've come to realize that there is a risk of a volar plate causing tendon problems. Remember that the concept of a volar plate for dorsally displaced fractures was so appealing because it might minimize the extensor tendon problems we used to see with dorsal implants. But as we become critical in our analysis of outcome, we've come to realize that the volar plates can cause flexor tendon problems, particularly the flexor pollicis longus. Can this happen on a time-related basis? It does not appear to be. Can this occur in patients who are not having symptoms? It certainly can. Can it be more complicated if an implant is placed outside the safe zone? Absolutely. So if it requires the placement of a plate more distally in order to get an adequate reduction in stabilization, perhaps that's okay, but we're now believing more and more that one should recommend plate removal at a certain period of time, particularly in younger individuals. The second critical aspect is, can a screw be used, although it's not functioning truly like a screw, to help stabilize, control dorsally displaced fragments, particularly the lunate facet? And we think it can in the large fracture fragment. It requires extension of the screw into the bulk of the fracture fragment. But we still believe that one has to be very cautious extending it beyond the cortex due to the risk of tendon problems. The data in this ICUC data collection support the clinical observations of prior publications regarding the risk of tendon problems with plate position and the outcome of use of the volar plate, if this is looked at carefully, and grabbing the dorsal lunate facet with the screws has shown on long-term follow-up to be very effective.
With the belief that more transparency in the practice of medicine will enable substantial progress, ICUC is launching a cutting-edge app to improve learning of surgical procedures in orthopedics. The app gathers complete, unchanged, and consecutive series of surgical interventions. Independent orthopedic surgeons record the interventions from pre-op to functional result to ensure complete recording, including surgical shortcomings. Download the app from the Apple App Store and access for free to a broad library of orthopedic case studies. Try ICUC app and discover a new learning experience.